Hi, everyone, and welcome. I'm Jim Schultz. I'm the Director of Governmental and Public Affairs for the New Jersey Dental Association. Thank you for joining us today. With me, I have Dr. Sidney Whitman and Dr. Steve Geierman. Dr. Whitman is a pediatric dentist practicing in Hamilton, New Jersey. Dr. Whitman is a graduate of Rutgers University and NYU College of Dentistry and the Temple University Pediatric Dentistry Program. He also completed a GPR at Newark Beth Israel Medical Center, where he is the Director of Pediatric Dentistry and the Chairman of the Residency Selection Committee. Dr. Whitman is a fellow of both the American College of Dentists and the International College of Dentists. He is the Chairman of the ADA Medicaid Providers Advisory, Chairman of the New Jersey Oral Health Coalition, Chairman of the NJDA Committee on Medicaid, President of the Dental Lifeline Network here in New Jersey. He is a former managing partner of a large multi-specialty practice. Dr. Whitman lectures throughout the country on behalf of the ADA. Welcome, Dr. Whitman. And also with us, Dr. Steve Geierman. Dr. Geierman is a retired captain in the U.S. Public Health Service, serves as the senior manager addressing access, community oral health and infrastructure and capacity within the American Dental Association. He coordinates the ADA's Medicaid Providers Advisory Committee and its Culture of Safety and Dentistry Work Group. As a former Indian Health Service and federally qualified health center dental director, he is a strong supporter of improving oral health of the public, especially those who are unable to access oral health care. Welcome, Dr. Geierman. And I know you danced your way through dental school, so thank you so much for being here tonight and dancing with us a little bit. The pandemic has truly driven America into a world of uncharted waters. Here in New Jersey, and frankly across America, we're seeing a staggering number of unemployment and an escalation of people applying for public assistance, like Medicaid. Sadly, the cost of dental education has skyrocketed, and we're seeing fewer dentists participating in this program. Here in New Jersey, only about 30% of the licensees participate in some way. Dr. Whitman, what would you say to a young dentist about accepting Medicaid patients?
Well, I think it's the socially responsible thing to do. And certainly if you have open time in your schedule, even though the fees are slightly lower, maybe even more than slightly lower, it makes some sense. Jim, it's commonly thought that Medicaid patients are unreliable and don't keep their appointments. I got to tell you, that's not accurate. You can't make that as a blanket statement, not anymore, and certainly, and I've been doing this a long time. If you create value in the patient's mind, they come. You do have to be aware, we have social determinants of health, we're all aware of that. And in the underserved population, education, environment, economic stability, food insecurity, all of these issues come into play when someone comes to our office. But for the most part, I will tell you, once they understand the value, they're coming. So that's how I would answer that. So I would tell a young person, and I'm very active in a residency program. I tell them, treat Medicaid patients. If you have open time, especially, why not? Something is better than nothing, and it makes some sense, and you're doing the right thing.
Some dentists believe that only large group practices can afford to accept Medicaid patients. I know you don't believe that, but maybe you could articulate a little bit why you think the solo practitioner, who makes up about 50% of our membership, would actually benefit from taking Medicaid patients.
Well, I think that certainly the larger practices, because of the economies of scale, are more economically suited to do it. But that doesn't mean that the single practitioner can't. If you can be an efficient single practitioner, you could easily see a limited number. You can't see tremendous numbers, but because that wouldn't make sense to you. But certainly on a limited basis, you can certainly see them and do a good job if you have an efficient system and an effective system.
Every little bit helps. Thank you, Dr. Whitman. Dr. Geierman, you certainly have the wonders of perspective, not only from your experience in the application of dentistry, but also looking at the national models. What are some of the innovative actions that you've seen in other states to drive Medicaid participation? And would any of them work here in New Jersey?
Well, Jim, I would point us back to the Take 5 scenario. It was originally utilized in Georgia successfully, and it was resurrected recently in Colorado. When we say Take 5, that is interpreted in very broad terms: 5 individuals, 5 families, 5 whatever. The point is, you participate. The participation does make a difference in the overall demand, but it's demonstrating to the state Medicaid program, as well as the state legislators who actually have something to say about funding the program, that organized dentistry is part of the solution, not simply labeled as the problem. So I would say Take 5 is something that is worth thinking about. Another is, look back to the original Michigan Healthy Kids program, where providers did not know if a child was a Medicaid recipient or a recipient of private insurance. It leveled the playing field, and it did make a difference in kids getting care. Lastly, I would just point to those states, and New Jersey happens to be one, that have a family-centric approach to Medicaid. When I can treat a child and take care of the mom and dad, there are role models at home, and the amount of recurrent decay is lessened tremendously. And it makes a difference for providers when they do a lot of work on kids, especially, to know that that work is not going to be wasted and have to be redone in 2 years. So Take 5, Healthy Kids, and a family-centric approach with adult and child Medicaid participation. Thanks.
New Jersey is fortunate to have a comprehensive adult dental benefit in its Medicaid program, and not all states do. So it was a perfect segue into that comment. But Dr. Whitman, if you were looking, what would be your top 1 or 2 things that you would change in your current Medicaid program here in New Jersey?
Well, first of all, let me say that I think the people in the administration of the program, the dental directors of the MCOs and the dental directors in the state do a pretty good job. They do a great job, but we have issues. Provider credentialing is a terrible problem. There ought to be what we call provisional credentialing. Why should it take 4 months on average to be credentialed? You first have to get a Medicaid number, then you have to apply to the MCO to be credentialed, and they do it via a third-party administrator. And again, this affects access to care. It just doesn't make sense to me. I know there are other states that do it differently, and they get their people credentialed very quickly. We don't do a good job in that in New Jersey, and I think there is no reason why we can't have provisional credentialing. If someone's willing to see the patient, why not? If a kid comes out of dental school and he's going into a private practice and he's not accepting insurance patients, he can see them the next day. What the heck's the big deal? They're talking about liability, but there's got to be a way to have some credentialing. There's got to be a meeting of the minds here and put the patient in the center of this deal.
Mm-hmm.
Dr. Geierman, as you well know, when you talk about Medicaid, the conversation doesn't go too far along before someone brings up money, reimbursements. Well, we're at that point in our conversation too. Some states, to increase Medicaid funding, have opted for a single payer system. Other states like New Jersey employ multiple managed care organizations to best manage the Medicaid population. In your opinion, is there a panacea? Is one better than the other? And what actions have you witnessed that have led some states to make bigger investments in Medicaid dental than others?
So I would say, I don't think it really matters whether you have 1, 5, or 17. 17 is much. How New York does that is beyond me. But there's some basic simple thoughts that you just have to keep in mind. One is addressing the concerns of the network providers. Illinois, where I live, is a 1 MCO state. And it really didn't matter who had the contract, the dentist hated them. And they would be very vocal about that. And I would listen for a while, then it's like, stop. It's in the contract. This is what you said the managed care organization has to do, and they're living up to that contract. If you don't like something, you need to put that in the contract. And that's the piece that I would say to you, Jim. It's look at the original request for proposal that a state puts out to solicit managed care participation, and make sure that it's meeting the needs of the residents of your state, but also the providers who make up the network. Our sister council at the ADA, the Council on Dental Benefit Programs, they graciously, at SID's request, they put together a Medicaid contract toolkit that is available online at ada.org, and it outlines what a state should have or consider when they put out an RFP for Medicaid managed care within the state. And the kind of things that Sid just mentioned, provisional credentialing, and I could go through others, you put those in the contract and people will bid on those. But if we got 5 out of 8 of those items, that's a start. And the other 3 become negotiating items. So I don't think the panacea is in the number. The panacea is in what's the contract that you hold the managed care organization their feet to the fire. And in theory, since you put it out there and they agreed, we shouldn't have to hold feet to the fire. We should be working together and moving things forward. I may be Pollyanna in that, but that's a good starting place.
So following up on that for a second, use your crystal ball. What do you see Medicaid in the next decade?
I would honestly see more people eligible for Medicaid and less provider participation. That's why we're having this discussion. So there needs to be a greater involvement and emphasis upon prevention. Less than 50% of the people in this country access dental care regularly. We need to be able to adequately address their oral health from a multitude of access points. And providers, dentists, who actually stress prevention need to be compensated for it. Currently, dentists get compensated for doing something. Hygiene aside, when does prevention happen? In most cases, it's while I'm waiting for you to numb up. And if I'm working another chair or 2 or 3, then hopefully my dental assistant is carrying the water for me. So we need to make sure that we're bringing forward a value-based care system that's fair to everyone. And that means we need to compensate dentists for keeping people healthy. And it's kind of leading into one of your later questions, I believe.
You know, could I
Go ahead,
comment on that?
Dr. Whitman. I'm certainly was about to jump into the next one, but Dr. Whitman, please go, because I'd love to
You
hear
know,
your perspective.
in New Jersey, we have about 30% of the dentists who signed up to be eligible to treat Medicaid patients. In truth, only about 10% of them see a significant amount of patients. That's not enough. There's a reason for that. First of all, the reasons are the fees are not quite what they should be. And number 2, the administrative burdens that are cast on the potentially cast on the providers. What happens to the threat of an audit? You know, they need to, when Steve talked about the contracts, they need to talk about educating the doctors on how to navigate that system. The insurance package, you know, sometimes the way that the doctors view it and the patients view it is that the insurance package is dictating the treatment. And you have to learn how to navigate that system, because that shouldn't be the case. If that's just the case, the system will not work. You need really the patient at the center of the care, not the insurance company dictating what that patient is going to get. That doesn't make any sense to me. And I just think that what happens is when the auditors come in, and I understand the reason for auditing and things like that. You know, it's a combination approach. The federal government pays money, the state pays money, and it's our taxpayer dollars. But in truth, wouldn't it make sense if those HMOs or MCOs, whatever you want to call them, Medicaid, started to see a problem, they would have a dialogue with the dentist rather than wait until there's an issue and then come in and penalize rather than have educated along the way? I think that if they were willing to do that, if there was a dialogue, you'd have more people involved, more dentists willing to participate in the system. So I thought that was a caveat to what Steve was saying.
Well, and along that theme, as it's often said in dentistry, healthcare frequently forgets that the mouth is the portal to the body. In your opinion, how critical is it that we begin to stitch the fray between medicine and dentistry? It sounds like you're both alluding to the fact that as we start to look further down the road, that we need to have better integration so people understand the value on both sides of that equation. What initial steps can we take here in New Jersey to begin that process, if you agree? And what are a couple of the key advantages and disadvantages, frankly, of medical and dental integration? Dr. Geierman, are you seeing anything at the state or federal level where policymakers are making headway in this area?
I am. It's challenging because whether it's at the ADA level, or I'm sure it's the same in New Jersey, there's part of your constituency that truly believes we need to break down the dental silo. But at the same time, as I take a brick away, I have colleagues that are digging the moat deeper and they're replacing those bricks as fast as I can take them out. They're not bad, but they're scared of what they perceive our medical colleagues have given away in terms of autonomy within their professions. So they're looking at a very narrow focused. On a positive note, many of our students and residents, including myself, and I've been a dentist almost 40 years, I was lucky. More and more healthcare professionals are training together. They see the value of an interdisciplinary approach to addressing the needs of the patient, who should be at the center of these discussions. And it's true, whether it's across the lifespan, from pregnancy to little kids, people with chronic diseases, HIV, diabetes, cardiovascular, and the fact that our esteemed elders are retaining their teeth longer, oral health is not an option. And we need to be thinking in that regard. And there are congressional people that actually get that. Data alone will not do it. We need to have the stories to tell. So Jim, when you go and make the case, to be able to have a grandma with you, and grandmas never advocate for themselves first. They advocate for their grandkids, their kids, and then themselves. And the thing about the graying of America, grandmas vote. And they know the value of healthcare in a bigger picture. And what they don't know, that's part of Sid's comment he just made about educating the public as to the importance of oral health. So we have to break down those silos. And I'll end by saying we need to put an electronic healthcare system together. We could put a human being on the moon 50 years ago, but medical and dental electronic records still can't talk. Something's wrong with that equation.
Dr. Whitman, my old boss, Congressman Bob Franks, would fondly say, you don't need a law to do what's right. So what is right? What would you say to the New Jersey Dental Association and its members, how we can better integrate the medical and dentistry model here at the Dental Society level?
Well, I think in various aspects in New Jersey, there are groups that are working with medical issues, medical societies. I know that the AAP and the AAPD in New Jersey work closely together. I know that, you know, when we see that the average pediatrician sees a young child before the age of 3 approximately 12 times, and we know in dentistry we start the child no later than age 1, there's a link there. We ought to be cross-referring all the time. And we had it actually in the Medicaid system for a while. They had a program where the pediatricians were applying fluoride varnish to the children's teeth and then sending them to a dentist for an examination and a referral. And they actually got a referral fee. There were people that some of the MCOs thought that that was outlandish. I thought it was the most wonderful idea ever invented because you were starting to see more children. If you look at the statistics, the very young children are not being seen at the rate that they should be seen. We know that. You want to talk about money? The younger a patient is seen, the better the prognosis, and the less dollars will be spent orally, and the healthier that child will be. So I think the more that we can do, we ought to embrace that rather than worry about whose turf it is.
Mhm. Jim, if I could,
Of course,
had
Dr.
brought-
Garman.
thank you. You had brought up the idea that reimbursement comes into play in these discussions. And in terms of medical dental,
In my world, it frequently does.
it does. So I just want to give you an example. And it lies, the heart of the problem lies in the fact that we don't have dental diagnostic codes. So let's say I'm an old guy and you're a young guy, and we're going for our physicals. So we go see an internist.
I appreciate you calling me a young guy.
Exactly. And you are so healthy, you are in and out in 15 minutes. I'm a decrepit old guy. I take an hour. That internist who saw us, she can bill appropriately based on the severity of the illness that was seen or wellness and the length of time that it took. So she is able to bill appropriately. Now you and I are going to see Sid Whitman. And you fly through in 15 minutes. Complete exam. I should have mailed my teeth in earlier, it would have been easier, but I take an hour for a full exam. When Sid bills, what does he bill for both of us? The same code. He gets paid the same amount of money, whether it took 15 minutes or an hour. There is something to be said about being able to use a code that talks about the severity of what is presented in front of you and the length of time that it takes to address it. So I just bring that up as a piece of practicality.
So where do we go to fix that? As a guy who's in the fixing business, where do we go to fix that?
So I was at Michigan and I was talking to 10 FQHCs, and all 10 of them hated their electronic dental record and they were going to ditch it. And what I learned as I listened, they were all going to ditch it and they were going to buy the stuff that the other ones were throwing away too. So I'm giving a presentation and it's time for a commercial, and I stopped and I said to them, this is what you're doing. And I used my analogy of man on the moon 50 years ago. We still can't have electronic health records talking. Just as we have RFPs for managed care organizations, what are the 10 things that an electronic health record has to do? You put that in the contract, and when dental industry says, can't do it, you buy nothing. Money talks. Henry Schein, Epic, EagleSoft, take your pick. They're all walking down these roads. And it can be here faster than we want, but it's all about money. And we have to hold their feet to the fire in this case, because if we don't, who's suffering? It may be my practice, but in reality, it's my patient, because I'm not seeing them as a full person. Sid, did I get that right?
You got that right. You know,
There you go, Jim. What more do you need?
Yeah, you got it.
The more technology we get, the more fractured it becomes.
Well,
So I want to turn our focus before I let you both go, because this has been such a great conversation, and I truly appreciate you both being here. I love to listen to you both. Your perspectives are absolutely outstanding, and I'm so thankful we're able to bring this to more folks to hear your perspectives, because I think they are really not only insightful, but progressive as well. So let's turn our attention very briefly to that tiny little subject, the other part of CMS that exists, called Medicare. As you both know, at present, Medicare does not have a dental benefit. Some advocates in this last go around have pushed strongly for a dental benefit in Medicare Part B in the federal Build Back Better legislation, only to see it fail. As some would say, due to its own weighty price tag of $35 billion. Even with our own dental community, there was not unanimity regarding inserting a dental benefit in Medicare. Can you briefly weigh the pros and cons of a Part B benefit? And while you're thinking about it, would a targeted benefit reserved for our most vulnerable seniors be a better way to go?
You go first, Sid.
Yeah, well, I would think that a targeted benefit would be the way to go. Certainly the concerns of the dental community are that the patients with private insurance are going to all move over to Medicare, excuse me, and therefore the dentist will be seen at a reduced rate, the same patient pool, which they're concerned about. And I understand that concern. That being said, you're going to have a greater number of patients who couldn't see the dentist be able to see the dentist. So I think if you had a targeted benefit rather than open to everyone, I think we'd be better off. I really do. I think it'd be a win-win situation. Those that need it will get it. I don't know if Steve agrees with that, but that's okay.
Well, I'm going to be signing up for Medicare in 4 months, so I'll tell you. But I would say, Jim, that whether it's Part B or Part T, neither of those, using your word, is a panacea. What I think we need to be doing is organized dentistry at the state and the national level. We need to be at the table with other oral health advocates. And this ties into not just dental. Dental is something I do with my fingers. Oral health is the bigger picture. We should come together, and there is a letter of the alphabet between B and T that we could agree upon. I do have to disagree with Sid. I don't agree with the idea of limiting it based on income. I believe that healthcare is a right, not a privilege. And if we're looking at Medicare, oral health is not separate. It's part of the overall scenario. And there are people within the ADA that would have a stroke that I said that, but there are others that would say, and my point to them would be, you hired me to present alternatives. What you choose to do, we all have to agree upon. But Jim Schultz asked me a question, so I had to answer. So that's my song and dance.
Well, I'm going to ask you one more question before I let you both really go. I'm going to pull that crystal ball out again. I'm going to say, so is there going to be a dental benefit in Medicare in the next decade?
Yes, and it will have eyes and ears as well, because those are in the head, and we're attaching the head back to the body.
Yeah, I would agree that you're going to have a Medicare benefit of some sort for sure down the road within the next 10 years. Not a question in my mind about that.
Well, thank you both for your time today and your fantastic insights. You've really given us all a lot to think about. I truly personally appreciate your insight and perspective. I learn every time I get to speak to both of you. It's been 20 years for me here at the association, so thank you for continuing to allow me to grow under your watchful eye and your tutelage. Everyone out there, for more videos like this, please visit njda.org or ada.org, and remember to follow us on Facebook and Instagram. Thank you all and have a great day.